Good morning, everyone. I'm Dr. Tara Karen. I'm a family doctor at the St. Michael's Hospital Academic Family Health Team and the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm delighted to welcome you back to our bi-weekly Community of Practice. This is a Community of Practice co-hosted by our department at U of T, as well as the Ontario College of Family Physicians. I'm going to turn it over right now to Dr. Jennifer Young, who's the president of the OCFP, for a short intro. Jennifer, you're on mute. Jennifer, can you unmute yourself?
Yep. Welcome to all, and there's no Zoom meeting without that glitch. I thank you for joining us, and I look forward to to hearing from our panelists. Thank you to you for coming. I would like to start to say this has been a really engaging way to hear from you and hear your questions and hear about your solutions. Thank you. Today we're talking about changing the way we work, embracing virtual care. Before we start, though, I would like to acknowledge that the land on which we're hosting this meeting is the traditional territory of many nations. We acknowledge that Ontario is the home to many diverse First Nations, Inuit, and Métis, and that each of you are joining us from one of those many traditional and treaty territories. We are grateful to be able to come together in this way.
Thanks, Jennifer. We all know that the land acknowledgement is also a great time for us to reflect on injustices faced by our Indigenous people here in Canada, even today. We know that Indigenous people are probably more likely to get COVID-19 because of some of the medical and social vulnerabilities. Unfortunately, though, we don't have the data that we need to actually best understand this problem, and this has been highlighted recently. So the data we have is incomplete and usually from on-reserve First Nations communities, as opposed to Indigenous populations living in urban areas. And we know there are a lot of Indigenous populations in urban areas. So I just wanted to highlight on the next slide work done by one of my colleagues, Andrew Pinto, about the importance of collecting race-based data during COVID-19. We know we've had a lot of discussions about this provincially, and his team at the Upstream Lab has done some critical thinking about this issue. And so if you're interested, please check out their website at upstreamlab.org. So welcome to our series on changing the way we work. This is a series where we want to learn from you because we know that there isn't a clear, easy, right answer right now. I wanted to acknowledge our committee who helped to plan the session, Patricia O'Brien, Leanne Clark, Susan Taylor, and Mina Viscardi-Johnson, as well as the many people behind the scenes, including Brian De Silva, who's controlling the slides and all the IT right now. So our team developed the content for this COP. You can check out our past sessions on our website. So this is the website address, and one of my colleagues will put it out on the chat. We encourage you to go there. You can take a look at the old webinars and watch them if you have time, but probably even more useful than that are some of the resources we've compiled. And for those of you on the call 2 weeks ago, you know there were a ton of resources circulated on mental health and addictions. And we've actually pulled together a 2-pager PDF that's there on the website that you can download and reference in your practice. Next slide. So today I'm really delighted to welcome our 3 speakers who are going to speak about virtual care. Dr. Steve Klassen from Thunder Bay, Dr. Payal Agrawal from Women's College Hospital in Toronto, and Dr. Paul Gill from Goderich, Ontario. We're also delighted to continue to be joined by Dr. Jennifer Young and Dr. David Kaplan, both of whom have important provincial roles and can help bring that provincial perspective and answer many of your questions. I'm now going to turn it over to our panelists to allow them to introduce themselves and speak to their own disclosures. So Steve Klassen, are you able to introduce yourself first?
Sure. Thanks so much, Tara, for the opportunity to join here today, and I'm looking forward to the discussion. I'm from Thunder Bay, and I'm work in a family health team, or actually it's a family health group in Thunder Bay. I work in long-term care a bit. As far as my disclosures, my only disclosure is that I also work for OntarioMD, and so during this I'm paid during this work to help other physicians, and one of my passions that we'll hopefully get a chance to talk about is how to simplify virtual care a bit more. Do you want me to get into?
Nope, that's great, thank you. Pyle?
Sure. Hi, everyone. Thanks for having me. My name's Pyle. I'm a family physician at Women's College Hospital and also an early stage researcher. My research for the last sort of 4 or 5 years has really focused on understanding virtual care and how we can better implement virtual care to support patient care, particularly in primary care. So I'm really excited to be here to talk about some of my learnings through that. And just as a disclosure, I have previously consulted for the Center for Effective Practice, as well as Apple, and I do receive some funding support for my research through the Department of Family and Community Medicine at U of T, and my time today is being funded through an honoraria by the OCFP.
Thanks, Pyle. Paul?
Hi, good morning. Thank you for having me. My name is Paul Gill. I'm a family physician in rural Goderich, Ontario. I have a practice model, which is a family health team. We use Practice Solutions here. It's a true rural practice, so I have hospital, emerge, anesthesia, you name it, hospice. We probably do a little bit of everything in my community here. In terms of disclosures, I'm new to the Peer Leader program, but I am getting an honoraria for the time being spent this morning doing that. But for the past 5 years, I've been involved at the Southwest LIN level as the clinical digital lead, and then also supporting the Partnering for Quality team and their digital coalition in the Southwest region as well. And currently, I'm the chair of the Southwest Primary Care Pandemic Response Table.
Thanks. So we're looking forward to hearing from all of our panelists. I'm going to just share my own disclosures. So I'm lucky to be supported in my research through a number of different institutions, and also have received grants from different institutions, which I've listed here, all of whom are nonprofits, with the exception of Gilead Sciences, where I received a grant to study curing Hep C in primary care. David?
I need to unmute myself, very important for virtual care. I'm David Kaplan. I'm the Chief of Clinical Quality at Ontario Health, where I receive salary support. I'm a family doctor in North York, on staff at North York General Hospital. I work in a multidisciplinary office of about 10 family doctors, soon to be 10 family doctors, and I'm receiving support from the Ontario College this morning. Looking forward to answering all sorts of questions in the chat.
Jennifer?
Hi, I'm Jennifer Young. I'm the president of the Ontario College. I'm a family physician and a community physician in Collingwood, Ontario. I work in multi-role as a family physician, and have been the president since November 2018. Happy to be here. I have no conflicts or receive financial support.
Thank you. And so, of course, in addition to all of our fantastic speakers, we've got you here, and it's so wonderful to see the different areas of the province that you're coming from. Of course, a lot in the GTA, but also a big group from Ottawa, Orangeville. I think we've got some people up north as well. We've got Alliston, Orillia, Guelph. So really excited to have all of you guys join us today. And so much of this community of practice really depends on your interaction. Yep, so Brian, you can go to the next slide, and I'm just gonna remind people on how to do that. So if you have a question for our panelists, I encourage you to use the Q&A button. So the Q&A button is found on your bottom right of your toolbar, and just pop in your question there, and our panelists will answer it either by typing the answer or by speaking to it. But if you wanted to share resources yourself or connect with others on the call, please do feel free to use the chat. And we'll be monitoring both the Q&A and the chat during the webinar. And then afterwards, we do take the resources that are shared on the chat and Q&A and compile the resource list that we put up on our website. Next slide. So without further ado, I'm looking forward to starting our discussion this morning. And Paul, I think why don't we start with you first? You've talked to us about how you're a rural physician, and I understand just before COVID hit that you experienced some HR challenges in your practice. Can you tell us a little bit more about how your practice has transitioned to virtual care?
Yeah.
Some of the challenges and how did you address them?
Yeah, certainly. So this morning, I'm going to highlight really, there's a lot of strategy work that we've done in the Southwest region, but I'm not going to focus on overlying strategy or support infrastructure. I think other colleagues are going to speak to that a little bit, but I will highlight my own personal office practice and some of the challenges here. And so one of the challenges we had is just prior to the pandemic, we had our MOA or our office assistant essentially go off on maternity leave. So we had a changeover of staff and we had 2 covering staff individuals. And so that context in terms of new staff who don't know our practice necessarily created an additional layer of challenge as well. And then on top of all of that, my wife and I are actually a dual family physician group. So the challenges of minding for 2 children during a pandemic while balancing each other's practices. She does emerge work, I do anesthesia work, so we're both on call trying to split, who's doing what and managing inpatient or in-person visits as well certainly was layered on top of all of that. The additional challenge in some of our rural areas, and especially mine, is rural internet. So even prior to the pandemic, we had started a process of actually collecting emails and sort of transitioning and getting our patients to start using our Ocean platform for pre-appointment questionnaires. So a little bit of that work had already been done. And so what we did once the pandemic started to hit was really focused on simplifying our processes for our new MOA staff, so we weren't having to train them on the technologies themselves. In my own practice, what we've done is initially we got in my community, there's a resource called Partnering for Quality. So we had our MOAs connect with Partnering for Quality, who actually have an ability to train and facilitate practices in how to do virtual. And so really what they did was gave our MOAs some very practical snippets from the OntarioMD website, which I'm sure we'll highlight shortly or later on this morning, highlighting how to do a consent and what content should go into a consent. And so really for me as a provider, it's been very straightforward to actually host and run a video visit. My admin staff actually at the time of booking an appointment, first ask patients directly whether they think they need to be seen in person. And so if our patients think they need to be seen in person, I will get a quick flag or a flipped message just asking me if I think they need to be seen in person. And if there's a disconnect there, we try to do a virtual first approach where we're either doing a telephone or a video visit. If we both concur that an in-person visit is actually necessary, then they will be booked in that way. And there's a color-coded appointment flag, so I know what the appointment model is, and I can be in the right setting for that visit as well. And that's all in an effort to conserve our PPE. Beyond that, we've really focused on simplifying the process. So the consent for a video visit or a virtual visit is all done by my admin staff. The note is actually initiated and the consent is dropped in there. And then typically when I call or connect with a patient, if that consent is in there, I'm just asking the patient directly if they'd like me to review that consent process. And most of the time, I'm essentially being told, no, I've done that, and we can actually focus our time on the appointment itself. The additional thing from a practice management perspective that we've done is really focused on not stacking 2 video visits one right after the other. And the purpose of that is really if there is a connection or an IT connectivity issue, it gives us a little bit of buffer time to go from one system to the next and make sure our patient-centeredness is really part of our equation here. And the final piece that I'll highlight is that really during the pandemic, there's been an opportunity to explore multiple different technologies, right? And this has been an incredible opportunity for me to play with, whether it's Doxy.me or the OTN platform, or I'm also on the Think Research virtual care platform. So, whether it's any of these different platforms that in the pre-pandemic era, I probably would have had to pay for and explore and understand and commit to. I've had the opportunity to actually open and use everything in the toolbox that I feel like using or patients prefer, and actually leave it to the patients to decide what modality they prefer. So I've had patients that tell me they want to use FaceTime. And so long as I don't have 2 video visits back to back, going from one system to the next, for me is not that challenging. So we've kind of just ensured that we have the time to go from one to the other. That's kind of it in a nutshell. I will say that, it's been an absolute wonderful experience to allow patients to see a window into my home and have my kids running around in the background. And the inverse is also true. I don't think I've appreciated as much how much extra information that I would glean from a video visit beyond, just being able to see and talk to my patient. Beyond that, seeing their home environment and seeing all of the different aspects of what life at home is truly like. So appreciate the time. I'm certainly going to pop back in and answer questions later as necessary.
Thanks, Paul. So there actually is a question for you already from Don Crockett. Sorry, I'm not sure if I can pronounce your last name right, but Don's asking, what was the name of the group that trained your medical office assistants? And then he also had a second question, what video conference platforms are you using?
Sure. Yeah, so in my own office practice, in the Southwest region, we have a program called Partnering for Quality. Their team is available and is supporting staff and primary care throughout Ontario Health West region. So the HNHB, Southwest, Erie St. Clair, and I've missed one, Waterloo Wellington. So throughout those regions, they are able to support as necessary in terms of providing bundled services and connecting you with the right team to get onboarded for change management and adoption as well. In terms of the virtual platforms, I would say most often I'm using telephone, which is the default backup. The preferred technology that I'm using right now is the OTN video visit platform. And what I've really done from an education perspective is my admin staff usually offer the OTN platform as the primary, but do offer what is your preferred. So I've had patients say, I want to use FaceTime, and they go through a little spiel just to explain that that's not an encrypted or as protected, and the server database and all those kinds of privacy aspects. And most of our patients, or at least in my experience, most of our patients have had a very keen desire to pursue what works for them. And so what we've really done is said, hey, if it works for you, I can make it work for me. Understanding the privacy concerns and making sure that consent has been completed is the key.
Thanks, Paul. I wonder if this is a good time to bring up the slide OMD news. Brian, if you could bring that up, because you talked about, actually, Brian, if you could bring up the website, OMD website, that would be great. Sorry to change my mind there, but I think this website, OMD News, is a really great resource. And maybe you could talk us through, Paul, and Brian, if you could scroll down. I think somebody asked about the video platforms, and I know that if you keep scrolling down, there's a great, maybe we can stop there, Brian, and Paul can speak to this a little bit.
Yeah, so the OntarioMD website is broken into different sections where you can actually see video platforms that are created for medical care. So these are the ones that have PHIPAA compliant technologies where you can actually safely go in and utilize these. For some of them, there is a change management adoption process where you have to register to use the system, and some billing implications with the OTN one where you have to bill using a specific mechanism. But there's a lot of detail here. The challenge with the website currently is that it's not the user interface. If you first come to the website, you won't actually see any of these technologies listed unless you click on the purple banner, which isn't actually quite obvious. And if you scroll down further, you will actually see additional technologies mentioned that are typically not in the healthcare space under the next blue banner there, which is the not traditionally used in healthcare. And you'll see things like Zoom, and I'm using that as well. I'm using FaceTime, I'm using Skype and Microsoft Teams. Google Hangouts for me has actually been one of the easiest ones to utilize, simply because many people have a Gmail account, and it's very, very straightforward. In my area, the challenge really has not been the technology part as much as it's been the rural internet connectivity. And so our fallback has been, hey, if people are trying to show me moles and lesions and they're choppy and I can't really make out what they're saying because of digital connectivity issues, our fallback is the telephone. This does have some additional support tools, such as the scripts that you can use for a consent, and that I believe is higher up. And then there are additional technologies here in terms of just making sure that if you're faxing requisitions or trying to get connections to your patients to share like a lab rec, that there are other technologies like Health Myself that can be utilized for that. And those are all listed on this platform as well.
Thanks, Brian, for showing the website, and thanks, Paul, for pulling us through it. David, you've made a couple of comments on the chat with your patients. You just that we are not the pandemic to comment. Not sure if David's.
I'm having some internet issues. I don't know if you can hear me. Just give me a thumbs up. I'm gonna try turning off my video. I'm having some internet issues. Can you just give me a thumbs up if you can hear me? Oh, is Dr. Kieran? I can't hear either from Dr. Kieran.
We can hear you, David.
Oh, okay, good. Okay, perfect. I think it was Dr. Kieran was having some issues. She was just mentioning what I had written in the chat box, which was, for those of you who haven't seen it, that two comments. The first is that the only reason we're allowed to use non-secure platforms right now was because the privacy officer gave us an out because of the pandemic to make it easy to get up and running. So they're not long-term solutions. We do as a profession need to explore the secure platforms that we'll be using moving forward. And then the only other thing is that we've really found a need to offer a video visit over the phone as opposed to video or telephone, because telephone is sort of the path of least resistance, but I do think you lose a lot of cues just by relying on voice. And given the fact that there are so many now free platforms, even the secure ones, for now at least, that they're free, I think it's a great way to start using the video platform, getting patients used to it.
Hi, so sorry, I got kicked off Zoom for some reason, so that was a bit weird. So I missed your what I'm sure was a really thoughtful reply there, David. So thanks for stepping in. So I'm going to turn it over next to our next panelist, Steve Klassen. So Steve, I know you've really embraced virtual care in your own practice, and I think some of your approach really relates to keeping things practical, simplifying technology, looking at the silver lining. Can you share a little bit more about your own journey and your reflections?
Sure. Yeah, I guess where I want to go first is just this whole aspect of doing house calls. It's almost like we're getting a chance to get back to our roots and do virtual house calls. And I'm, like Paul, really enjoying getting to see people in their own environments and getting to meet their pets and meet their parents and meet their partners. I'm finding this, as Paul described, I'm learning all kinds of things about my patients. And I'd love for somebody to answer why I feel so much more tired when all my visits are telephone. Somehow it sucks more energy out of me. If I get more when I get more video visits, I think it's less tiring. And I have definitely noticed that seeing more patients in person again, it's just been such a relief. But, if I have to choose which way to do a virtual call, it's going to be by video. And so we always offer it, but not pushing it hard. I find that my elderly patients are doing just fine with this. And as Paul is describing, that my goodness, go with what they are comfortable with. Go with, so, yes, I've got my own built-in in TELUS. I've got a virtual care video conferencing medical grade, but my goodness, if the patient's having any difficulty, we either switch over to FaceTime or just to telephone. Like I bail very quickly if there's any technical problems. Try to make it low stress for people. And I find that that's going well. And I don't know what percentage of patients I'm seeing by video, but I'm always working at trying to increase that. Just thinking I've been trying to do a bit of group medicine this way as well. We've done some counseling, and I'd like to do some more diabetic visits and these kind of things a group way with using things like Zoom. I'm just thinking if there's any other where you want me to go right now.
Maybe can you expand a little bit, Steve, on the group visits you're doing, because that seems like a pretty unique initiative. I haven't heard of a lot of people doing virtual group visits as a physician. I know the Association of Family Health Teams of Ontario has been providing some guidance to other health professionals for restarting groups, but tell us about, how you've been doing it, what topics you use, and what platforms, and how it's been received.
Sure. So before the pandemic, I'd already had a men's health group that I had been doing. I just found it incredibly valuable, and it was going so well. But one of the challenges was new guys coming and joining. And I'm finding now that, the bar to enter is so much easier. You don't have to show up and wonder if you want to leave or not. You can show up in a video visit and have technical difficulties and disappear with no difficulty. So, I think there's a nice opportunity here for people that are otherwise really nervous about interacting in groups. I'm finding that there's very low dropout. Once people do get there, we're so engaged and so valuable to everyone. This is a wonderful way to do medicine, and I find they're helping each other, and there's so much that happens beyond just what I've got to offer. So I'm looking forward to expanding that into other areas like diabetes, and just doing it using whether Zoom or using Google Groups, Google Hangouts, these kind of things make it nice and easy.
Yeah. So can you tell us a little bit more about the platforms you're using, Steve, and which ones you end up preferring?
Yeah, I mean, like Paul, I'm just doing with whatever the patient is comfortable with. So I'm not all that platform loyal at all.
Sounds like you leave it up to your patients, which is, I think, a really great strategy. I see that there's lots of discussion going on in the chat, which is fantastic. And maybe I'll get, Paul, you spoke a little bit, you've been sharing about the logistics of actually booking on the chat. Maybe I'll come back to you, Paul, if you have a moment to just speak to that out loud about how you're doing the pre-booking for video visits.
Yeah, I find practice flow is integral to making this work, right? And so one of the challenges that we had initially when we started this was that I was booking video visit after video visit, and to go from one system to the next system and not necessarily know, am I flipping from OTN to phone, or am I flipping from OTN to a Zoom? The challenge of flipping from one technology to the next for me was just a little bit hard pressed. And so what we did was we simplified our process to say, when my admin staff are doing the booking, they're finding out what is the preferred platform, and in the schedule themselves, they're color coding using a standardized legend that we essentially have created for our office practice to say any yellow highlighted visit in our EMR happens to be a phone. So I know without going into the chart, just by looking at my schedule for the day, yellow is phone. And we try to make sure that our blues and our greens, which are other technologies, have a little bit of phone visit patients between them to buffer that out. Which does require my staff on occasion, when they've stacked too many video visits, to call a patient and say, hey, can we flip you by 15 minutes so that Dr. Gill can flip from one to the next technology? And then the other question that came up on the platform was with OTN delegation. And in my particular clinic, just with our HR changeover, at the risk of inconsistency, what we really did was to say, hey, you know what, we're not going to delegate any technology to our admin staff themselves. They're going to outline the process and where I need to connect. And I'm the expert now in so many different video technologies, as I'm sure we're all starting to become. And so we've really left that part of the connecting to me. Our patients are essentially told, just be ready, sit by your computer. You'll get an email from myself, if I'm using the OTN platform as an example, minutes before the appointment. And then really that connection is through a desktop computer that we're emphasizing for ease of use and consistency as well.
Thanks, Paul. I'll just highlight a few other comments in the chat. I think David Kaplan was mentioning how he uses Accuro EMR, and Medio is integrated with Accuro, so it's easy to use this kind of integrated platform because there's a virtual waiting room. And then I think someone else piped in, I think it's Christina, that Accuro has sort of different dots or colors that you can use for video and phone, which make it a bit easier too. People have been asking about whether people are getting technical issues with OTN and has it gotten any better. I myself use OTN, and I personally actually haven't experienced that with patients. I don't know if others on the panel have experienced it or have any comment about that.
So I did have challenges up front with connectivity. Those in the last number of, I would say in the last month or so, I've really not encountered any challenges since that point.
Great.
I would say, sorry, yeah, I would say that one of the challenges around it is that if they have an iPad as their device, they have to download an app, and teaching patients to do that, who I find my elderly patients tend to have iPads, and then you're in that double difficulty of downloading an app and then getting it so that it works. So I have found that challenge.
Mm-hmm.
I think one of the interesting things that has been, though, that a number of the vendors, because of what Dr. Young was just talking about the difficulty with downloading an app, have really rapidly over the last, I'd say, 2 months, adapted and created a web app version of their solution. So it does work in an iPad, Safari, or Chrome browser. It's been really interesting to see what's pushed them to move off their proprietary. It's not every vendor, but definitely there's been a number of vendors that have moved to realizing they have to create something that's frictionless. And I think that whole idea of virtual care not being frictionless has been very difficult for a lot of us to adopt in our profession. Like we need to make it easy. And I think we're hearing a lot of that today. Like, how do we make it easy for people? So for Paul, there's a meso level infrastructure to support that in his region. And not all of us on this call, the 90 plus of us on this call, have that level of infrastructure to help with the change management.
Yeah. And I think also not all of us, in fairness, feel as comfortable on many different platforms, I'd say. So Don here has mentioned how he would prefer to have one preferred platform for staff and patients to be comfortable with. And I will say, Don, that's the approach that I myself have taken, where I preferentially use OTN eVisit platform because it's, in my case, the one that's most recommended by our institution. Our institution also supports Zoom, the PHIPAA compliant version. And the advantage of Zoom, to your point, David, I think, is that many people are more, it was Jennifer, that many people are more comfortable with Zoom already in their personal lives as opposed to OTN. I see a couple of other good questions about providing guidance to patients who are less tech savvy. So maybe we'll answer that question, and then we'll move on to hearing from Pyle. So Jennifer Tran has asked, do you have any tips for providing guidance to your patients who are less tech savvy? How do you avoid them from getting frustrated by technical issues? And I'm going to put this out to any one of the panelists who wants to jump in.
I guess I would say that I don't think my patients are very frustrated with the technology, right? I'm avoiding OTN for exactly having to have any kind of download issue. I like what exactly David's saying. So I think the frustration level is, if the video quality isn't great, we switch over to telephone. Like that's as far as I get with this. And so, I hear that people are sort of reacting to that, hey, we're using too many platforms. Well, really what is my platform? Well, it's the built-in one. That's the virtual care that's right in my EMR. That's my preference. And if that doesn't work for any reason, I switch over to FaceTime is probably that's common. And, and just, I don't use lots of different things every day, but I'm comfortable if there's somebody who wants to do something else. And so I guess my point is, don't make it frustrating for anybody. That the telephone is your backup, and try another video visit the next day or the next time.
And I would simply add the expectations. I think for us, there's a little bit of expectation management in my own practice for myself, right? My patients have never used virtual video platforms, and the infrastructure for all my patients to have already the app pre-downloaded for OTN, as an example, they haven't done that. So there hasn't been an education component. There hasn't been a mass communication to all my patients to say, even before an appointment, go ahead, go download the app. And so it's often happening at the time of appointment booking. And what I'm seeing already, even though it hasn't been that long, is the folks that have struggled and had some challenges up front because they had to download an app, the second time through, the struggle is actually much smaller and the challenge has actually started to wane itself. And whether that is change management adoption from my clinic and my team, or it's on the patient side, it's probably a little bit of both, but I anticipate that this challenge will actually get easier and easier and easier as the technology and your consolidation of what you're going to use in terms of, instead of using 8, we're going to start whittling down to these are our 2 platforms and our 2 mechanisms. Your patients are actually going to start to be a little bit easier to connect with as well.
Thanks, Paul. So I'm going to turn it over to our final speaker, Pyle, to tell us a little bit more about her experience leading a provincial-wide evaluation of a virtual primary care pilot. So this would happen even actually before COVID hit. Pyle had the opportunity to lead this evaluation. And I wonder, Pyle, if you could tell us a little bit more about the virtual care pilot and what it was all about and what you learned from it.
Sure, thanks. So I was involved in a pilot or a project that started almost 2 years ago, which I'm sure many on the call have actually been a part of, entitled Enhanced Access to Primary Care, so EAPC. And for those aren't aware, it was a pilot done in partnership with OTN, Ministry of Health, and many others to really try and understand how to better implement and support virtual primary care across the province. So the pilot was powered by 2 different technologies. There was the Novari platform and the Think Research platform, each which enabled secure asynchronous messaging, telephone, and video visits. And as part of the pilot, which made it kind of an interesting evaluation, was that there were billing codes attached for people who were physicians who were participating. So they actually got reimbursed for the time they spent on these virtual visits. And over the year of our evaluation, we sort of looked at the experience of patients and providers. We had almost 200 providers across the province, 6,000 patients and 14,000 visits. So actually a really nice, prior to COVID, but a really nice sort of space to understand what virtual care means in a primary care context for both patients and providers. And I think I just wanted to reflect on a few of our biggest learnings today and how they might be relevant in a sort of our current COVID situation. So the first thing that I want to reflect on is, we've heard a lot, there's been a lot of discussions up till now just about video versus telephone, which I think maybe in part reflects the current billing structures. But in this pilot, I think what was perhaps really surprising and not expected was by far the vast majority of visits were conducted by asynchronous messaging. So over 80% of visits were conducted by asynchronous messaging. And I think that's really important to remember. We talked about frustration with technology, but sometimes, the really simple technologies, emails, messaging back and forth can actually provide great care and great value to both patients and providers. So I think that was, a really important learning, and particularly in a primary care setting. I think that's really important to think about and reflect on as we move forward. The second piece of learning that we had, so You can imagine this was, again, prior to COVID-19, virtual care was quite new for many providers in a virtual care setting. And we heard concerns about, will patients abuse this or use it too often or use it inappropriately? Because with those platforms, patients were able to initiate or request a visit on their own. And really what came out over the course of the evaluation, both from providers and kind of over time and the quantitative data, was that patients really weren't sort of misusing the technology, and they're actually really good at using it appropriately and even sort of appropriately being able to triage themselves between the different modalities. So understanding what was appropriate to sort of request messaging to deal with and what was appropriate to sort of request a video visit to sort of work through. So I think that's a really important insight sort of as we move forward and think about how we continue to use virtual care in our practices. And then the final piece I wanted to reflect on, and if we could just put up a slide. I know a lot of people, as we sort of move forward into understanding, how to balance virtual visits and in-person visits moving forward, we did actually get reflections from over 30 of the physicians in the pilot, asking them, again, this is in a pre-COVID context, what they felt were like appropriate and inappropriate use cases for virtual care. So again, this comes directly from primary care providers across the province. And I think this is, we can see that here that there's a lot of cases where there was really just sort of consensus from chronic disease management to medication renewals, following up on a previous diagnosis, that really, everyone felt was quite appropriate to do by virtual care, and that even includes assessment of a rash. Some places like mental health and palliative, different providers had different opinions. And there were places, again, in a pre-COVID context, things like prescribing narcotics, giving bad news via asynchronous messaging, where providers felt like in-person care might be would probably be the way to go and the more appropriate approach. I think as thinking in a COVID context, we know obviously now there's a much greater risk to an in-person visit than there was sort of when this data and these reflections were collected. But I think, obviously things here that are shown as appropriate use cases in a pre-COVID world, I think would continue to be appropriate use cases in a COVID world for virtual care. And some of the inappropriate use cases might mean you just need, a little more reflection and discussion with a patient on sort of the risks and benefits of virtual care versus coming in person, and making a bit of a decision on a case-by-case basis around some of those pieces. So those were really sort of some of the learnings I wanted to share, and thanks for having me, and excited to answer some more questions.
Thanks, Pyle. There was actually a question about, which medical problems do you find don't lend themselves well to virtual visits, and do you have tips to offer for situations where one might not expect to be able to conduct the assessment virtually, e.g. MSK? And I think some people have replied, that ultimately that is when sometimes people do bring them into the office, and I find sometimes MSK exams where I might be worried about something is a reason to bring somebody into the office. I don't know if you have any further thoughts on that question, Pyle.
Yeah, I mean, I found, at least in my practice and what we've reflecting on some of those learnings, again, I think there's use cases which are completely appropriate virtually, and then some of those other ones, one, a discussion with the patient, and two, I think we've heard before this idea of a pre-visit. So perhaps bringing people in, doing a history, gathering information, and then sort of bringing them in just for a quick visit to sort of do the physical exam, limit the in-person interaction sort of as much as possible. And then perhaps even sending them out the door and then doing a post-visit and doing all your counseling and stuff back on the phone, So I think maybe shifting our idea of a visit from being a very discrete point in time to maybe kind of spacing it out and using different modalities for different parts of the visit can help us kind of adjust and limit in person, but still provide the care that we need.
Right.
I agree.
There have been some questions on the chat about billing. Paul, I don't know if you wanted to speak to that in the link you sent out.
Sure, yeah. So the link is actually broken. I've just realized that clicking it. So I will put another link up from the OHIP bulletin specifically. So from a billing perspective, there are various technologies, and some are pilots. And I think, I don't know if Dr. Agrawal, you want to speak to the Think Research pilot and the billing mechanism there. But If you have registered with OTN, you have to register with OTN to bill OTN specific codes through OTN. So if you are using that platform, that is the mechanism there. And with the OTN platform, the nice thing is you'd be able to bill your usual billing codes with a code that actually signifies that it was done virtually as well. And in the SLI indicator, you would put OTN as the location of the intervention. For all other billing, typically that isn't OTN based, I'm using the temporary virtual K codes across the board for my patients. So regardless of practice model, you should have the ability to bill for these visit types for the time being. And my understanding, when you look across at ACOs in other countries and practice models where virtual has been around for a while, and I start thinking post-pandemic, what will the world look like? I don't think virtual is going away. And I don't think, in our environment in Ontario, I don't think there's going to be an appetite to turn virtual away either. So I really think, whether the codes change or not, virtual is here to stay, and a billing mechanism is likely here to stay as well. And positioning my practice really so that even post-pandemic, ideally, I'll be doing about 40 to 50% virtual. So, yeah.
Yeah, I think we also do have to acknowledge just that, even with those codes, I think, there's a comment that the income has continued to go down because the volumes are down. And so just do want to acknowledge the, the difficulty that means for a lot of our family doctor colleagues across the province.
I was just going to make a comment about the billing. So this is definitely an issue that we've raised at Ontario Health, because we want people to use the appropriate and the best platform. And it seems odd that if you use one technology, you could bill codes that are out of the basket if you're in a FHO, for instance, but if you use a different technology, you can't. And the kind of bill or the kind of visit shouldn't dictate whether or not you're going to use OTN or if you're using Oscar or whatever built-in solution there is for Oscar. I think this was a matter of the switch flicking on very quickly. And we have to remember that those codes that we're billing now for virtual, the non-OTN codes, were just telephone codes 17 years ago during SARS. And so the codes existed, they flipped them on, they said you could use telephone or video. I think over the summer, we need to sort out this, there shouldn't be two different ways to bill for the same work, right?
Thanks, David. And Paul, I noticed you sent out the revised link for the OHIP bulletin, so thanks so much. Don, I think you've asked Pyle, when you refer to asynchronous messaging, are you suggesting we text back and forth with our patients? So maybe you could just clarify what you mean by that. And then he is asking about the billing and saying, I'd have trouble managing my time with charting interaction without a more structured appointment schedule. So maybe you could speak to that platform.
Yeah, absolutely. So yes, with asynchronous messaging, the platform, so both the Novari and Think Research enabled what was essentially text messaging, but via secure platform. So not kind of directly off your phone, but you would send a text and it would ping a patient on their phone or via email. So it really was messaging back and forth. And on average, it was about 3 messages by a patient and 3 messages by a provider to sort of complete a visit. There are, of course, billing challenges relating to this type of work in this current environment. Some providers are able and have been for a long time doing this similar kind of work through things like email. But the Novari and Think Research platforms are available, for people to enable secure messaging. But unfortunately, in order to enable the billing, I think currently there's sort of a restricted set of licenses. So you'd have to sort of talk to your region to see if there's licenses available in your region. So that is sort of a little bit of what David was speaking to and how things shifted very quickly with COVID. There's unfortunately not broad billing at this point for the asynchronous messaging work.
Yeah, I appreciate hearing that so much, and because it just reflected what I've been doing already. I know I might shock people to say that I've been using using messaging with my patients for years, and I'm fee for service. I don't get paid anything for it, but patients really respect it. I gradually have used it for even my borderline patients, and my borderline patient the other day said, I know it's just about end of office time. Is there time for one more interaction, and very respectfully. And I don't put a lot of time, and I use it even in borderline patients, use it a bit of teaching around boundaries. And I really find that I'm having very little difficulty. It's enriching my experience with patients, and I'm not finding I'm spending a ton of time on it. So I may shock people with that, but it reflects what I think I'm hearing. Is that right, Pael?
Yeah, and I mean, in terms of the workflow, I think what we found is providers implemented virtual visits and things like asynchronous messaging very differently based on their own personal kind of work types. So some people would block off an hour at the end of the day to do that work, while others sort of integrated it throughout the day and throughout the practice. And some of the feedback we got was people actually really liked having a moment to be able to reflect on what the patient's saying, come up with an answer, and then provide it versus, the phone where you have to react in real time. So I think, it's a bit of depends on providers and what works for them. But over time, it's not easy up front. As everyone knows, integrating virtual care, takes time. But over time, a lot of providers were able to find a flow that worked for them in the pilot.
I wonder if this might be a good time, Pael, you can maybe also, you've been involved in something really innovative, the COVID Care at Home program. Do you want to tell us just a little bit about that? I know it's a bit different than what we've been talking about, but I think integrates some interesting use of virtual technology in COVID.
Sure, yeah. So at Women's College Hospital, we've built a program called COVID Care at Home, where we're really looking to support patients with COVID-19 in the community. We know, of course, we've heard a lot about the impact on acute care settings with patients with COVID-19, but the vast majority, will be managed at home, but will require support both for sort of the medical concerns and monitoring medical symptoms, but also a lot of sort of the psychosocial and mental health issues that come with a diagnosis of COVID-19. So we've built a program where we connect with patients virtually, primarily by video, but also telephone when it's what the patient prefers. And we check in on them every day if they're sort of more high risk, or every 2 to 3 days if they're more low risk, with a particular focus on patients who are unattached in the community or at higher risk for complications. So to date, we've connected with over 150 patients. I think what's really interesting, reflecting a bit on what Steve said, that idea that you can actually get quite intimate and get with a patient-provider relationship even over video. Like, these were all patients we had no prior relationship with. And we're really able to connect with both them and their families and their homes, understanding things like how they're getting groceries, how they're isolating in smaller cramped quarters, from family members so they don't get COVID. And as well as really building a pretty complex interdisciplinary team model with nurses and social workers and pharmacists coming in and out of meetings or appointments with patients virtually. We've also sent pulse oximeters and been able to sort of remotely monitor patients with pulse oximeters, which has been really helpful. So it's actually been a really nice way to use the pandemic to understand how we can sort of, in a much more strong way, use virtual care to build new ways of supporting our patients. And it's had great response from patients and providers. A lot of our providers were initially reluctant, but have actually found it to be a really great way to provide care for these sort of high-risk patients.
Thanks, Pael. I wonder if this is a good time, Brian, for you to pull up that slide on the OntarioMD peer leaders. And Steve, maybe you can speak a little bit about this program, the OntarioMD Peer Leader Program that you're a part of, and the value you think it might have.
Thank you. I've been an Ontario peer leader for MD peer leader for a few years now, and I just love helping other colleagues figure out the technology and try to make it work for them. And I tend to find the magic in it, and it makes my day better, and try to find ways to help others. And I do find my colleagues at times overwhelmed with everything and what to do. And so getting to talk to a colleague about where the technology is working for them or not. Hey, this is a case where you don't even have to ask us for a favor. We're actually paid to do this. So I think the link is going to be provided that, you can request a peer leader to help you out with figuring out how to integrate this into your practice, have a one-on-one visit where your colleague is actually being paid to help you out. So I just encourage people to use it for whether it's virtual visits or for any other part of increasing access to the tools that are available.
Thank you, Steve. So I was wondering if one of my colleagues could put the chat out on the chat, the link for people to be able to find the OntarioMD peer leaders. I'll go to the next slide, Brian, and then the next one maybe after that. And David, I wonder if you could speak to this new service as well that we wanted to let others know about.
Absolutely. Thank you so much for highlighting it. So these are two services that we've rolled out. One, both to support long-term care and retirement homes. These services, the one is a low-tech 19th century technology or 20th century technology, which is a phone line. So this is for people working in retirement homes and long-term care homes across the province, and this is 24/7 access to general internal medicine consults for urgent issues. There's a 1833 number. It's 1833-82-HELP-YOU. And it took a long time for us to find the right toll-free number combination, but we did find one. This will get you a consult with the hope that it prevents a transfer to the hospital, either to the emergency department or to requiring admission. What we found for a lot of clinicians working in long-term care, it's been very, very helpful for their discussion with families to say that they did get an internal medicine consultation and that the internist had some ideas or that the internist agreed with the expected plan of management. About 40% of the time, it seems like it's resolved the issue and does not require a transfer to an acute care facility. The second is a virtual care app that's being rolled out provincially right now for the next 6 months at no cost to the homes. This connects with about 90% of EMRs being used in long-term care homes in the province. So those of you on the call who are familiar with using point-click care or Medicare in your long-term care homes, you would continue to use your same login and password, which we know is really important for everybody. Right now, the license is per home. So once a home is on, all the clinicians that work in that home have access. But it does allow, if you're ill yourself or you have medical issues and you aren't able to get into the home to provide care, it allows for the nurse to connect you with your resident in. If your home has not yet started this process, there's about 130 homes that have. You can start that process yourself, and that's why we're starting to reach out to individual family doctors that are providing long-term care coverage this week.
Thanks so much, David. So we only have a couple minutes left. I just want to acknowledge lots of great questions in chat on the chat box and the Q&A. We unfortunately aren't able to get to all of them. I do want to acknowledge again, people's comments about the income and that potentially leading to early retirement. And I know that is something the OCFP and David at OH and others are very well aware of and working on. Pyle, I wonder if you could answer Don's question just in the chat itself. Thank you. I think you've just done that. And I know a few people have asked questions and they're in the answer box, but maybe the last question I'll put out is an interesting question, but from James Lowe. Do you foresee a future where we're able to do all virtual care, where we don't have to pay for real estate, for example, and have minimal virtual staff?
I personally think that the virtual models are going to challenge our paradigm for how we provide care today. I wouldn't go so far as to say that they're going to completely remove that in-person aspect. I personally don't see how you could run an efficient practice without seeing patients in person, pushing on a belly, listening to a heart, in terms of those key pieces. So I think it's going to challenge what we do and how we do it, and our practice models are likely going to change over the coming years. But I don't think it's going to eliminate the in-person aspect, and I don't think it should.
Thank you, Paul. I think, to your point, it's changing things already. And I know there was lots on the chat about boundaries. And I think what was interesting was the contrast. Pyle, you said people didn't use it inappropriately, but I think some colleagues reflecting that it is hard. People do expect 24/7 care. And I think David and Paul, you've made some suggestions for just trying to be clear around expectations for answering things. We hope to have a future session also on supporting teaching, because I know that there was a question about how do you support teaching medical learners in this kind of environment. And so, as we end today, we've discussed a lot, and hopefully you've some practical tools to take back to your practice. But we also have more things that we need to discuss. And so at the end of today, we're going to ask you to fill out an evaluation and suggest topics for future COPs. So if you want to hear about anything specific, please put that in. We appreciate it. We urge you to go to the OCFP website. We know a lot of us are thinking about ramping up in-person primary care. So there are a lot of really relevant resources there. There is also some new ministry guidance that has come out for primary care, and I think that will be linked on the OCFP website. Our own website at U of T Department of Family Medicine hosts our COVID community practice webpage, where you'll be able to find resources in a few days related to this webinar. And of course, if you have any questions for us directly, you can email us. Thank you so much to all of you who participated today, and we look forward to seeing you guys again in a couple of weeks. Take care.
Thank you.